Let's get into the nuts and bolts of insurance. So we've talked about a little bit what insurance is and why we have it and the economic um, underpinnings of insurance. But let's actually dig into types of insurance and how they really relate to EMS budgeting and EMS finance. So um, for ambulance payments by payer, Medicare is by far the largest payer of ambulance payments. This is both emergency and non-emergency services. It's followed by private insurance and Medicaid. And then we've got some self-pay payers out there, and then other types of payers. And I think the biggest one in that other category is probably like a workers' comp type of situation. But by and far, Medicare is the largest one, followed by private insurance. Now on the collection side, you might be thinking, well, we send them a bill and they pay it, and maybe the patient pays some sort of copay, right? It's not necessarily the case. So we do decide what to bill, and we send that bill out. But then it arrives on the insurer's desk. Let's say it's Medicare, so it arrives to the Medicare offices, and they just don't pay the bill and just send us a check, right? They decide how much to pay. Luckily, they've told us how much they're going to pay for EMS services, ambulance services, but we can bill them all we want. We can send them a $10,000 bill, but if they say that the rate is $500, that is what they're going to pay us. And annually, there's about $3 billion in uncompensated ambulance bills, EMS bills, largely because we decide to charge a lot up and over what, let's say, Medicare has told us they're going to pay. A lot of private insurers also follow Medicare's policies, so kind of in the same boat with them. So it's not necessarily a we bill and they pay it. It's we bill them whatever we want, and then they pay whatever they want. Now you're probably pretty familiar with our current state of insurance and insurers and kind of how it works. But a little quick history, how do we get here? It's kind of starting in the 1800s, late 1800s. Um, we had naval sailors, railroad workers being offered injury coverage. It kind of morphed into the early 1900s, and then in the 1920s, Baylor Hospital down in Texas offered a plan that covered their services. This is what became Blue Cross. Blue Shield was added later on, but it covered hospital services. So if you wanted to use Baylor Hospital, you could buy this kind of primitive type of insurance that covered hospital services there at Baylor. In the 1930s, healthcare costs were going up, out of pocket. Medical costs were going up, and the Committee on the Cost of Medical Care was formed to kind of dig into the issue, into the problems, and make some suggestions. We'll hit that here in just a few seconds. 1960s, that's when Medicare, Medicaid came around, and then that's been tweaked, bits and pieces here and there, different parts added here and there over the half century or so. And then 2000s, the Patient Protection and Affordable Care Act was passed. That's otherwise known affectionately as Obamacare, and was one of the other big health insurance legislative milestones. Switching back to the 1920s, the Committee on the Cost of Medical Care was super important because it was really the first to tackle rising healthcare costs. And in the 1920s, healthcare costs were starting to go up. Physicians were, for the most part, charging their own rates. Hospitals were charging their own rates. It wasn't really a standard way to mitigate any of those costs if you became sick, if you became injured. So in 1926, the Carnegie Foundation sponsored this committee to look into reasons for rising medical care costs and ways to mitigate those costs. Carnegie Foundation was also behind the Flexner Report in the 1910s, give or take a few years. Flexner Report was influential in defining medical education. in the United States. So Flexner went out and visited every medical school in the United States and wrote a report and said what a medical school should be, what standards should be. So this is the same Carnegie Foundation that sponsored that report, that sponsored the committee on cost of medical care. They published a number of reports through 1932. They published a final report with suggestions, some recommendations. There were 5 majority recommendations from the committee and then 7 minority recommendations. Not the report itself, but an overview of the report with the recommendations, both majority and minority, is up on Blackboard for you. In the 1960s, we got Medicare, Medicaid. So just remember, and this bears repeating over and over and over again, that Medicare is by far the largest payer for our services. So Medicare, its origins, it goes back decades and decades, but really grew out of the Kerr-Mills Act in 1960, which laid the foundation for Medicaid, or Medicare, Medicare itself. Finally passed in 1965. So the Kerr-Mills Act had been passed and had been in effect for a few years. Medicare was formally established in 1965. The Social Security Act established both Medicare and Medicaid. Currently, give or take a couple people, Medicare covers 52 million people 65 or older, and about 8 million people aged younger than 65 years. So Medicare covers other conditions. If you have end-stage renal failure, for example, you would be eligible for Medicare. Little changes like that have been instituted over the years, but Medicare came about 1965 and covers about 60 million people. Medicare is broken up into 4 parts. Part A and B were the first 2, again passed in 1965. Part A covers hospital costs, hospital services. Part B covers your medical preventative medicine. If you go to your primary care physician, Medicare Part B is going to cover that. Every Medicare beneficiary has both Part A and Part B. Later on, Parts C and D were included. Part C is your Medicare Advantage programs and Medicare Advantage insurance programs and insurance plans. And Part C covers these plans cover what Parts A and B don't. Right. So there are some services that they cover, Parts A and B, but maybe don't cover very well. Parts that they don't cover. So Part C kind of fills those holes, and these are called Medicare Advantage plans. And I'm sure you've seen plenty of infomercials for Medicare Advantage plans. Part D was added on a little bit later, and these expand coverage into prescription drugs. The Medicare coverage of prescription drugs isn't the best on the face. So Part D expanded prescription drug coverage. Medicaid was established at the same time as Medicare. Again, Social Security Act of 1965 covers low-income individuals and covers about 65 million people. So between Medicare and Medicaid, we're covering somewhere between 120, 130 million Americans. With Medicaid, it is overseen at the federal level, but it is partially state funded. Medicare is completely federally funded, but Medicaid is partially state funded. And each state determines eligibility. So here in North Carolina, eligibility for Medicaid is going to differ a little bit from, let's say, Virginia or New York State. So the states have a little bit of leeway and a little bit of oversight over their Medicaid programs. Another program for low-income families, it's a state children's health insurance program. I believe it's been shortened to just the Children's Health Insurance Program. Again, federally mandated, partially state funded. These are for families with children who don't qualify for Medicaid. perhaps their income is a little bit too high to qualify for Medicaid, but a little bit too low to really afford um, health insurance plans for their family, and so they can qualify for this S-chip program, and it covers not the family, so not mom, not dad, not grandma, but will cover their children, and uh, nationwide covers about 7 million children annually. So Medicare, Medicaid, S-chip, and Medicare is our biggest payer. So how are we getting reimbursed? We send out a bill. They decide what to pay. So it's not a we bill, they pay scenario. So um, how are we getting reimbursed? First, we have a couple different models of reimbursement. One of these is the fee for service. So we bill for the services we render. We can bill for our response. We can bill for loaded mileage, miles we drive, any disposable supplies that we use, EKG electrodes, IV catheters. This is a fee-for-service model. We are billing for very specific things that we used for that patient. Capitation, on the other hand, is a payment model in which the provider is just paid a flat amount, one single amount per patient, and this is regardless of services rendered. So in EMS, ambulance billing, we're going to follow a fee-for-service model because that works for us. Capitation, you'll see that more with primary care physicians, maybe specialists, maybe your cardiologist is paid on a capitated arrangement where um, your cardiologist serves you and provides medical care for you. And the healthier you are, the lower the costs for your cardiologist, right? And your cardiologist is paid a flat amount per patient. Put this in different terms. Your fee for service is like going to McDonald's. You walk in, you've got a menu, you know exactly what you want. You buy your Big Mac, you buy your fries, you buy your drink, and it costs a certain amount for the Big Mac, costs a certain amount for the fries, costs a certain amount for the drink. You pay that, you walk out, and you've got it. The capitated payments, more like a buffet. You walk into your buffet, your Golden Corral, your Chinese buffet, you pay a certain amount for the buffet. You pay your $10 to access the buffet. Buffet has all the food you would ever want, but you paid a single price for all that food. So a little bit different payment models, but EMS we're definitely going to fall under that fee-for-service model. Now, how are insurance companies going to decide how to bill, what to bill? We've got ICD-10 codes and we've got DRGs. So an insurance company is going to look at a patient who goes into the hospital, say visits the emergency room. There's going to be an ICD-10 code associated with that patient. So these codes are very specific to the discharge, disease, condition, specific to patient complaints. So my insurance company knows that I was treated for appendicitis, and maybe it was a minor flare-up of appendicitis. There's a specific ICD-10 code for that. ICD-10 codes can get kind of fun and very specific. Got a couple of those up there for you. So it can be appendicitis, an emergency appendicitis with surgery needed. Right? It can be its own ICD-10 code. So my insurance company knows what it pays for that specific ICD-10 code, and it may have contracted and agreed with the hospital, my local hospital, that this is what we're going to pay for appendicitis, an emergency appendicitis with surgery. Same thing with the codes up there, right? I like the sucked into jet engine code because that assumes that you survived being sucked into a jet engine and showed up to the hospital. But ICD-10 codes are very specific to what what your complaints are, and what your discharge diagnosis is. DRGs, or diagnose related groups, are used by Medicare, much less specific than ICD-10 codes, but Medicare groups them out and uses this for their billing. So an example, DRG 291 is just heart failure. And they've got a few for heart failure depending on the severity, but it's not as specific as ICD-10s. You're not gonna find a DRG for pig bites, right? So a little bit more broad, and they're just used by Medicare. When it comes to ambulance services, what's going to be reimbursed and what's not? Broadly, an ambulance transport must be necessary and reasonable for it to be reimbursed, and these are all going to be Medicare definitions. But keep in mind that private insurers often follow Medicare's rules and guidelines. So transport must be necessary, must be reasonable. Our necessity means that any other transport method would be detrimental to the patient. If the patient were to go by car, it would be detrimental. If the patient were to go by bus or walk, it would be detrimental. And that transport must be to obtain a medical service. So you've got a Medicare insured patient, and he wants to go to the ER to refill his prescriptions. That will not be covered by Medicare because the transport is not to obtain a medical service; it's to obtain a prescription refill. That's not going to be covered. Under reasonableness, the level of service that is rendered by the providers, so by us, by the paramedics, must match the patient's need. So we can't, what that means is we can't bill at a higher level than what we necessarily provided. So maybe we provided a higher level than what was needed. You have a pretty simple patient, maybe a little nausea, doesn't feel good, general malaise, and you decide to start an IO and pace your patient, and then because you paced your patient and went into cardiac arrest, right? So the level of service rendered must match the patient's need. We can't provide a higher level of service just because we want to, and then bill at that higher level. Patient must also be bed confined. So bed confinement is not necessarily to do with the 911 side of things, but the medical transport side. Non-emergent transports, you're taking your patient from maybe a hospital discharge back to the nursing home, hospital discharge back to home. In order to qualify, be billable for an ambulance ride, patient must be bed confined, and your patient must qualify by meeting all three of these conditions. So first, they're unable to get up from bed without any assistance, so they need assistance to get up. They can't walk on their own because hand in hand with that assistance, so they're unable to ambulate. And this is an important one, and they're unable to sit in a chair or wheelchair, so they can't sit straight upright for whatever reason. So they must meet all three of these criteria to be bed confined. If they can sit up in a chair or wheelchair, Medicare will not pay for an ambulance, but it will pay for a wheelchair van or some sort of a van transport. Necessity and reasonableness and bed confinement, we don't necessarily need to determine on our own as paramedics. If you're a supervisor or administrator, your employees don't necessarily need to determine this on their own. Again, this is not needed for 911 responses. This is for interfacility transports. Necessity and reasonableness are assumed in the 911 setting if you're calling for an emergency. But in the interfacility environment, we're going to get a necessity form. We're going to get a physician certification statement. This is a signed form that says that they have determined that the patient cannot be transported by any means other than an ambulance. Again, not needed for 911, it's just interfacility or discharges, medical transport. So you pick up your patient, you need one of these necessity forms, and there are options for repetitive transport. So perhaps you've got a patient going to dialysis a few times a week. You don't need a necessity form every single time you take that patient to dialysis. There are some options for one form to cover 30 days of transport, or options to cover 60 days of transport. So perhaps that patient's physician has one of these forms, and it's a 60-day option, and you have it on file in your office, and that is good enough for Medicare. So if you show up to one of these repetitive transports and they don't have a PCS right there for you, it's probably filed away somewhere in your office. For interfacility transports, hospital to hospital, if you want Medicare to pay for um, your transport, not only does it need to be necessary and reasonable and your patient be bed confined, but you also have to have a form um, that says it complies with EMTALA, so the Emergency Medical Treatment and Active Labor Act in the 1980s that prohibited patient dumping. It says that if you're transferring a patient out of your hospital, they must be transferred to a higher level of care. They must be transferred for a reason. And on this form, you have to have the transferring physician sign it, saying this physician is transferring the patient over to the other hospital. You have to have the name of the receiving physician, so you know that there is a physician receiving the patient on the other end, and the name of both nurses at the time and the time of report. So you're going to take report from the nurse at the transferring hospital, and then on this form you need the name of the nurse who received a report at the receiving facility. So this decreases or addresses patient dumping. So if there is, let's say, an uninsured patient and the hospital doesn't want to take care of them because they know they won't be reimbursed for anything, they know they won't be paid for anything, and they just dump them on another hospital, this prohibits that. So anytime before you leave, you'll need this form. When all of this is satisfied, Medicare will reimburse us, and the transportation benefit falls under Medicare Part B. If you remember, Medicare Part B covers medical services like doctor's office visits. So we fall under Medicare Part B, and the transportation benefit states very clearly in their policy that the benefit is a transportation benefit, and without a transport, there is no payable service. So we'll discuss the ET3 model coming up here, I think in a lecture or two, a week or two. Medicare policy still states that without transport, there is no payable service, and a number of private insurers, most private insurers, follow Medicare policy. Also, and I'm sure you're familiar with this one, for Medicare to pay, the destination must be the closest appropriate facility, and Medicare will pay for the mileage to the closest facility, even if your patient opts to choose a different hospital. If they bypass the closest appropriate facility, Medicare will only pay for the mileage to that facility, and any mileage in between the appropriate facility and the chosen facility will be the responsibility of the patient. Medicare has set and defined varying service levels for ambulance service and reimbursement. And this relates directly to reimbursement. So it depends on what level of service you have provided to the patient. Remember that service must be reasonable, must match the patient need. First one, BLS and BLS emergency. So BLS services have been given, even if a paramedic is on the crew, part of the crew. If BLS services are rendered, so no ALS services rendered, even if paramedics on the crew, you fall under this BLS service level. The difference between emergency and just BLS is just that. It's a 911 call. It's not a scheduled transport. So scheduled medical transport would fall under BLS, while a 911 call that results in a BLS level service being given to the patient will fall under BLS emergency. Stepping up a little higher, we've got the ALS levels. We've got both ALS 1 and ALS 2. Under ALS 1, again, 1 and 1 emergency. So was it pre-scheduled or was it not scheduled? ALS 1, once you have an ALS assessment by a paramedic and at least one ALS intervention, so you started an IV, performed a 12 lead, some ALS intervention, you click up to the ALS 1 level. And again, must be reasonable. just because you have a patient with a stub toe splinter, complaining of finger pain, and you decide to start an IV and um, and run a 12 lead, doesn't necessarily mean that it will be reimbursed at the ALS level. But as long as you have at least one ALS intervention, you can now um, file a claim for it at the ALS 1 level. You can bill at the ALS 2 level when you have provided an ALS assessment and at least one ALS intervention plus um, at least 3 separate IV medication administrations, or one of those 5 services. So pretty invasive services, defibrillation, intubations, IOs, decompressions. If you offer, or not offer, but render one of those 5 services, you automatically can bill for the ALS 2 level. If you don't, but you give at least 3 IV medications, and these don't have to be different medications. So you can give 3 doses of morphine, 3 separate doses of morphine, maybe 3 separate doses of Zofran, maybe 2 doses of Zofran and 1 dose of morphine. Those are 3 separate IV medication administrations. And once you've hit those 3, you can bill at the ALS2 level. Medicare defines a couple more service levels for us beyond the BLS and ALS levels. One is specialty care transport. So services provided go beyond the typical scope, common scope of a paramedic, and we can bill at a SCT, specialty care transport level. For using paramedics, some states do recognize its own critical care certification. North Carolina does not. So if we were to want to bill at an SCT level, we've got an ICU to ICU interfacility transport, patients on a number of IV medications, maybe on the ventilator. If we want to bill at the SCT level, we're going to have at least a nurse on board the truck with us. If we have just a couple paramedics in the back, even though they might be critically care trained, maybe they have a critical care certification through UMBC or through University of Florida, North Carolina doesn't give out its own critical care paramedic certification. It doesn't say that on your card. So on your North Carolina card, it says paramedic, right? So because of that, we can't bill at the SCT level unless we have a nurse or someone higher on board with us. So if you go around the state and start looking at critical care services and how they run their critical care services, their trucks, their aircraft, it's usually either a couple nurses on board, or more commonly a nurse and a paramedic on board in North Carolina. That's exactly why. So we can build a specialty care transport level if we have that extra, we have that RN on board, not just a couple paramedics. We can also bill a level is called Paramedic Intercept. This is a pretty specialized service level, and in order to qualify for this level of reimbursement, if we want to bill for Paramedic Intercept, the agency must be non-transport capable. So all they do are offer paramedics maybe in QRVs or chase cars. It's going to intercept with a BLS ambulance, and that BLS ambulance cannot bill. So we are the ones billing. Our agency with the paramedic QRV are the ones billing. The patient isn't getting 2 or 3 bills. So the BLS ambulance isn't going to send the patient a bill, and then the intercept agency, that paramedic QRV, is going to provide the ALS treatment during transport. So this reminds me I spent some time in New York State, and I spent some time in an area where there was a volunteer ambulance agency that was staffed. The BLS level, there are 2 EMTs on the ambulance. They responded to all 911 calls. Volunteer agency, they did not bill the community. Their community supported. And then the town that they were located in provided a paramedic and a QRV. And this paramedic responded to the 911 calls. If it was ALS, paramedic would jump on board the ambulance and provide ALS service. So they would bill at a paramedic intercept level because they're providing that interception with their QRV. The SCT side might be a little confusing whether or not we can bill for specialty care transport, even if I've gone through a critical care course, but I'm a North Carolina paramedic, and in North Carolina, you're a paramedic or you're not a paramedic. There aren't any delineations among specialty certification, specialty training, or education. Compare that to picked out Wisconsin. There are a handful of states that do recognize critical care paramedics. So in Wisconsin, you can be a paramedic or you can be a critical care paramedic. So in Wisconsin, if they were to staff a critical care truck with let's say an EMT driver with 2 paramedics in the back of the truck, they can fully bill for SCT because the state recognizes critical care paramedics. Whereas in North Carolina and the majority of states, like North Carolina, do not have their own critical care certification recognized by the state. We've got our patient, we've got necessity, we've got reasonableness. They're bed confined, they need to go by ambulance. We've got our service level that we're going to bill at. Maybe it's an ALS1, ALS2, specialty care transport. So what is CMS Centers for Medicare and Medicaid Services? What is Medicare going to do with all this information, and what are they going to send us for money? Because we can bill them whatever we want, but they have told us exactly what they're going to pay. So first there's a base rate, and that base rate is $229.91. It's very specific, and that's what the base rate is going to be. I said for ambulance transport, that's the starting point, that's the starting number, and then we're going to look at other things like your service level, maybe like mileage, and then we'll keep adding on to that. We've got relative value units, which is a base rate adjustment, and this is dependent on service level. So that base rate is for your BLS level. So if we provided an ALS1 emergency level, our rate's going to increase a little bit, and we'll hit those RVUs here in just a few seconds. But this is going to adjust that base rate up from the BLS level if we did anything extra. And then we can also add in mileage, and the mileage reimbursement from Medicare is a little bit different from urban to rural, recognizing that rural areas you have to transport a little bit further, you have to travel a little bit further to get to hospitals. So the mileage reimbursement for rural areas is just a little bit higher. Then there is an adjustment as a regional adjustment. It's called a geographic practice cost index, and you don't need to memorize any of these. You can look them up all you want, but they're going to adjust based on your regional location. Going back to relative value units, or RVUs, our base rate is our BLS. Our BLS, non-emergency BLS, $229.91. And Medicare has defined RVUs for each service level. And RVUs are defined for any of their DRGs, diagnostic related groups. So even if I had appendicitis, there are different levels of appendicitis. Is it minor? Does it emergent and require surgery? There are different RVUs for that as well. So for the ambulance transport area and EMS transport, our BLS level is our base rate. It's got an RVU of 1. So you take that base rate, multiply it by the RVU, and that's the adjustment. So if we go up to ALS1 emergency at a 1.9, our base rate rises to $435 for an ALS1 response. And then you add on mileage, you add on the regional adjustment, and you get your final rate. So we'll know exactly what Medicare is going to reimburse us just by evaluating the RVU for a service and the mileage to the closest appropriate facility. For mileage, Medicare will cover loaded miles, so taking a patient from the scene to the hospital, patients in the back with you, they'll cover loaded miles. But CMS also allows you go to hospital to base, so they will allow you to bill from the hospital back to your station. Not every EMS service knows about this little rule. Many do, and then many do not. So Your agency does not, maybe suggest that you document mileage from the hospital back to your station, because CMS, Centers for Medicare and Medicaid Services, Medicare will allow you to bill for these mileages. Um, Base rate for mileage is about $7 from Medicare. Rural miles are going to differ a little bit. For 17 miles are about $11 per mile. So, um, those mileages from the hospital back to your station can um, can really make a little bit of a difference if your agency doesn't know about that rule. It is worth noting, though, that even though Medicare pays a little extra for rural mileage, just because you think you're rural doesn't mean that Medicare thinks you're rural. So it all depends on how CMS has classified your county, and these are easily look upable. So you can look up your county, look up your area, see if they've classified you as rural or not. So just because you think you're rural or think you're in a rural area of your county doesn't necessarily mean that Medicare has defined you as such. Um, with multiple patients in the back of your truck, what are they going to do? They're not going to pay full price for each patient, because it's one truck, one provider, and they're not going to pay 100% for both patients. So what Medicare is going to do is split it, and they're going to pay 75% of that base rate for that service level for each patient, and then they're going to split the mileage equally and pay 50% of mileage for each patient. So gain a little bit of extra money for stuffing an extra patient in there if need be, but Medicare is going to make an adjustment on their reimbursement for those patients. To put this all in perspective, I want to go through a few sample calls with you and see what we billed versus what we received. So I've got 73-year-old male, STEMI, uh, typical STEMI treatment, oxygen, aspirin, nitromorphines, a couple IVs, go to a cath lab, closest appropriate facility. Your agency, again, we can bill whatever we want. Bills $1,200, but we only get $500 because it's an ALS-1 emergency service level. We had the ALS assessment, we have ALS intervention, but we don't have at least 3 IV medication administrations or any of those highly invasive procedures. Right? We've given a lot of medication, but the only IV medication in there is 1 dose of morphine. So it's just an ALS-1 emergency collection. You'll see the collection rate down there at 42%. That's just a proportion of what we billed versus what we got. So you'll hear a lot about collection rates, maybe your agency's collection rate. And in this case, for this call, our collection rate is 42%, and about $700 or so has gone uncollected. This one's 67-year-old female, humeral fracture, apply splint, IV fentanyl, Zofran, and transport to closest facility, billing $1,000 for that. This one we can bill at the ALS-2 level, so a little bit higher level, because fentanyl, we gave 2 doses of fentanyl. Both those are IV medications. We gave Zofran, and we can assume that was an IV medication as well. So we gave 3 IV medication administrations. Remember, they don't have to be 3 separate medications. They can be the same medication, just 3 doses. So we've given 3 doses of an IV medication. So that automatically clicks us up to the ALS-2 service level, and so we get $650 for that instead of our STEMI, where we got $500 for him. For her, our collection rate is 65%. Again, just a proportion of what we billed versus what we collected. Another one, 88-year-old male, cardiac arrest. Go through the whole cardiac arrest protocol, CPR, defibs. We've got IOs, we've got intubations, we've got EPIs, we've got amiodarones, and we work him for 60 minutes, and then call it and leave him on scene, and follow our cessation protocols. With all of that, we bill Medicare $1,400, and we get $0. We can bill at the ALS-2 service level, because we've done defibrillation, one of those big procedures. We've done IO and intubation, one of those 5 really invasive procedures. Remember, we've given at least 3 IV medications. In fact, we've given 9, so we can bill at the ALS 2 level, but we get $0. And this is because of Medicare Part B states that there is no benefit without transport. So we left him on scene. We did not transport, so they will not reimburse. So any questions you might have, send them my way. Any questions, comments, concerns, or cuss words. So overview of Medicare, a little bit of Medicaid, a little bit of S-chip, and then how Medicare reimburses us and what we need to pay attention to maximize our Medicare, our CMS reimbursements.